Dear Chair, dear audience, welcome to my progress report. I'm Boglárka Fehér, and my topic is altered vaginal flora during pregnancy. I'm a medical doctor at the Department of Obstetrics and Gynecology at Semmelweis University. I believe that pregnant women will have better outcomes due to professional prenatal care, and I would like to find new possibilities of screening and treatment of genital mycoplasmas during pregnancy. To complete this mission, currently I'm working on two projects closely related to each other. I would like to conduct them both through systematic reviews and meta-analysis. First, let me talk about my first project, which is investigating the effect of genital mycoplasmas on adverse pregnancy outcomes. The genital mycoplasmas can be a part of the normal vaginal flora. Here you can see the prevalence is quite high. This is similar in pregnant and non-pregnant women. Mycoplasma genitalium is the only one recognized as an STI with lower prevalence. Unfortunately, evidence-based guidelines currently have no recommendations on genital mycoplasmas except for mycoplasma genitalium. The reason of that is the controversial data in the literature about pathogenicity. Nevertheless, there are plenty of adverse outcomes they can be related with during pregnancy, like preterm birth. Although these complications are very dreadful for pregnant women, early detection could be able to prevent them. So my aim is to investigate interrelations between genital mycoplasmas and adverse pregnancy outcomes. To reach this aim, I chose this clinical question. Do genital mycoplasmas increase the risk for adverse pregnancy outcomes? I'm going to investigate pregnant women. The exposure is genital mycoplasmas, the comparator is no genital mycoplasmas, and the outcomes are different adverse pregnancy outcomes. I hypothesize that pregnant women affected by genital mycoplasmas have higher risk for adverse outcomes compared to those without genital mycoplasma infection. I've conducted a systematic search in 3 medical databases, and I've ended up with more than 10,000 findings using the search key below. After the duplicate removal and the selection of the articles, I was left with around 1,000 eligible full text. As we have a large number of articles, the analysis is still ongoing, so I'm going to present preliminary results. Based on the data of 156 observational studies, we could perform both multivariate and univariate analysis. Multivariate analysis is focused on our primary outcome, preterm birth. In the first figure, the variable is a specific bacterial species. Here you can see that we could find statistically significant results for all species of genital mycoplasmas, with mycoplasma genitalium showing the strongest effect. Here you can see the odds ratio was 2.18, indicating that pregnant women infected by mycoplasma genitalium have twice the risk for having preterm birth compared to those without genital mycoplasma infection. Sampling site is a crucial variable as it helps to determine the optimal location for sample collection during screening. For vaginal samples, here you can see that we obtained statistically significant results for almost all species of genital mycoplasmas, except for Ureaplasma urolithicum. While for cervical samples, neither mycoplasma genitalium yielded significant results. This is clinically relevant because cervical sampling is typically recommended for the detection of STIs. When we involved all those studies involving cervical, vaginal, or cervical-vaginal samples, Ureaplasma urolithicum was significant as well. This is a subgroup analysis of preterm birth stratified into 2 categories, early and extremely preterm birth. For preterm birth before the 34th week of gestation, Mycoplasma hominis was associated with a four-fold increase in risk, while for preterm birth before week 28, Ureaplasma parvum was associated with a nearly 2-fold increase in risk. All these results were statistically significant with 0 heterogeneity. For preterm pre-labor rupture of the membranes, Mycoplasma genitalium was associated with a 14-fold increase in risk, and Ureaplasma species were significant as well. For clinical chorioamnionitis, Mycoplasma hominis and Ureaplasma species were significant, and the same trend was observed for histological chorioamnionitis. These 2 outcomes correlate. For spontaneous abortion, we obtained significant results for almost all species of genital mycoplasmas, except for Mycoplasma genitalium. I would like to highlight the strengths of our study, which is a large number of articles available for 6 outcomes of interest, and we could perform multivariate and several subgroup analysis. However, I also have to highlight the limitations, which is a high heterogeneity, as well as the presence of potential confounding factors and the limited availability of clinical trials. Here you can see the current progress of our project. Currently, I'm writing the manuscript and working on supplementary material. Our study suggests that genital mycoplasma infection is associated with preterm birth, so the routine screening should be incorporated into practice. However, to confirm causality, there is a stringent need for new studies based on molecular diagnostic techniques and randomized treatment protocols with promising and safe antimicrobials. Briefly, let me introduce my second project, which is investigating the effect of genital mycoplasmas on adverse outcomes in pregnancies at risk for preterm birth. Preterm birth, defined as giving birth before the 37th week of gestation, affects 11% of pregnancies worldwide and being the leading cause of death in children under the age of 5. Numerous risk factors contribute to preterm birth. Among obstetric conditions, preterm labor, which means regular contractions leading to cervical change before the 37th week, poses 50% risk for preterm birth. Preterm premature rupture of the membranes occurs when membranes rupture before labor, before the 37th week, results in preterm birth in half of the cases within 1 week. Women with short cervical lengths faces up to 50% risk for preterm birth. Infections contribute to the half of preterm birth cases, with genital mycoplasmas being a key factor. Administration of prophylactic antibiotics have not effectively reduced global preterm birth rates, highlighting the need for further research. So my aim is to investigate interrelations between genital mycoplasmas and adverse pregnancy outcomes in pregnancies at risk for preterm birth. This leads me to my clinical question. Do genital mycoplasmas increase the risk of adverse pregnancy outcomes in high-risk pregnancies? I'm going to investigate pregnant women with preterm labor, preterm premature rupture of the membranes, and cervical insufficiency. The exposure is genital mycoplasmas, the comparator is no genital mycoplasmas, and the outcomes are adverse pregnancy outcomes. I hypothesized that pregnant women at risk for preterm birth infected by genital mycoplasmas have shorter interval to delivery, higher risk for preterm birth, perinatal death, and chorioamnionitis compared to those without genital mycoplasma infection. By answering this question, I hope that our study could support practitioners in providing optimal management for high-risk individuals and utilizing effective antibiotic therapy to prolong pregnancy. We use the same search key and the same database as we did in our first project, and we were going to submit Prospero soon. To summarize, here you can see my future plans. I would like to finish both of my projects till the end of this year. Let me finish my presentation with a thought-provoking quotation by Mahatma Gandhi: "Be the change that you wish to see in the world." Thank you for your attention.
Congratulations on your very nice presentation and your progress with these many articles. My question would be regarding the first project that you mentioned in the limitations that is a limitation, the confounding factors, but in this topic, confounding factors like mother's age or smoking is very, very important. And do you have any means to address these confounding factors?
Yeah, so actually that's why we excluded all those high-risk populations from our first project and transferred into the second one, because preterm labor, preterm premature rupture of the membranes, and cervical insufficiency has really very high risk for preterm birth, and they could be very serious confounding factors. For age, smoking, and for recurrent preterm birth, which is the most predominant risk factor for preterm birth, we could convince them only in the risk of bias assessment, because we have only data about the characteristics of these mothers, and we cannot exclude them because we didn't know exactly who was infected by the genital mycoplasma and who is in the control group. So we cannot. We are thinking about IVF patients because we have studies restricted to only IVF patients, as they have a 12% risk for preterm birth, but we haven't decided this yet. There is about one study restricted to the twins, so maybe we will exclude it also, but the rest of that we cannot.
Okay, thank you.
Thank you.
So first of all, you said that also in the limitations that there are different type of methodology for the examination of the ureaplasma mycoplasmas. And my question is that in those studies that you were including, you were using only PCR or also cultures? And if you were also including cultures, did you have any quantitative information like colony-forming units and so on? Because I know that it's like more and more also even on the PCR you can have this information about the amount of the bacteria which is present.
Yes, thank you for your question. So it's a very important one because the detection of mycoplasmas is very challenging. So both methods have advantages and disadvantages. So we included both. And of course, we preferred PCRs, but we didn't exclude all the cultures, although they could detect only high loads of bacteria. But your second question, the load is a variable in the multivariate analysis. I haven't displayed the results because they were not significant yet, as we didn't determine the threshold yet, because it's very hard statistically. But we have some results about the load, and that's very important according to the pathogenicity of these bacteria. So we will. Thank you.
My other question is that would you suggest, I mean, we were talking about screening during the pregnancy and treating during the pregnancy if needed. First of all, what would you treat it with? What kind of antibiotics is currently in the literature? Because I remember that in the last few years there were not really any, especially about the ureaplasma, not really any recommendations. That's my first question. And the second is that would you suggest to treat those patients who are planning to conceive in the future, or it's only for the pregnancy? And when would you screen during the pregnancy?
So the second question, we don't have enough data to know if there is any association before pregnancy and genital mycoplasmas. We have only one study when they check from the endometrium by a biopsy if there are genital mycoplasmas or not. But it's only one study, so we couldn't have any conclusions. So we can't answer this. Sorry, could you repeat your first one?
What antibiotic you would suggest?
Yes, the treatment. Yes, it's also very, very challenging, as there is only one guideline, the WHO, and it's only for mycoplasma genitalium, which says that treat during pregnancy, but all the other guidelines says and recommends only considering treatments, considering screening. So because of the incoming data, and that's only mycoplasma genitalium, which we know it's an obligate pathogen, and the other ones they are not even mentioned. So that's why it's important, but they could be dangerous because of there is no routine screening because of the high prevalence rate, but they are asymptomatic. And there are some studies which examines this to confirm this causality with azithromycin, erythromycin, and josамycin. But there are some problems with these treatments. So during pregnancy, we have to take into consideration several factors, not just the antibiotic susceptibility, because resistance is increasing, but also the safety and placental passage too. So we can give macrolides during pregnancy because they are safe, considered to be safe. We cannot give fluoroquinolones and tetracyclines because they are FDAD drugs, but among macrolides, it's very hard because for erythromycin, almost all ureaplasmas are sensitive. It's very high, it's 90%. But Mycoplasma hominis is not, so it's totally resistant. For azithromycin, ureaplasmas are sensitive, but Mycoplasma hominis is not. Mycoplasma hominis is only sensitive to clindamycin, but ureaplasmas are not. So there is one drug, according to the latest epidemiological studies, it's josamycin, and it recommends to be josamycin, the first line empiric drug, because both ureaplasmas and mycoplasmas are highly sensitive to that, even to 100%. So maybe that's the answer.
Is it available in the European Union?
In Hungary, not, and I don't know in which country.
Thank you very much.
Thank you.